Doctor. He is Senior Director and Head Minimal Invasive and Robotic Cardiac Surgeries at one of the leading hospitals in India, Fortis Memorial Research Institute. Today's masterclass is about uh, robotic and minimally invasive cardiac surgeries. Over to you, Dr. Dhir. It's your meeting. You can start, sir.
Dr. Dhir, you are on mute if you are speaking.
Yeah, now it's fine.
Yes, doctor, we can hear you.
Okay. So today, this is the hospital. I am Dr. Dhir. I am the Principal Director and Head of Cardiothoracic and Vascular and Heart Transplant Surgery Department at Fortis Memorial Research Institute, Gurgaon. This is Delhi NCR area, and for Fortis, this is the flagship hospital in Gurgaon. So this is the overview of the hospital where I work. This is my hospital, and this you can see the lobby, where this signifies us daily that uh, how we are, and
Doctor, yes.
this is, yes, sorry, my slides weren't moving. That's why I saw. So this is the view from my OT. Somewhere here is my OR, and from there, this is the view which comes where you can see this, and it's just to remind you, yes, you have to bow down and whatnot. Whatsoever inference you want to take out, you can take out from anything. But it means a lot to us, and it is so calming. This is my OT. These are my team members, right from my OT staff to my technician. This is my senior anesthetist, Dr. Anand, with the transesophageal echocardiography, where the patient is induced and we are just assessing the mitral valve for repair. We do a lot of minimal invasive cases, and we are touching somewhere. We have crossed right now. This is a presentation, but we have already crossed more than 550 minimal invasive cardiac surgeries, which includes 65% valvular, 10% coronary, 10% congenital heart disease, and 15% thoracic cases. As you all know, surgery is an integration of knowledge, skills, and attitudes. There are 10 commandments which we follow. Need not follow those. I'm not going to take your time on following those 10 commandments, but the most important commandment which I say for any doctor, leave aside surgeon or a physician, is heal your patients. And second, if you cannot help him, do not harm him. That is the motto. Do the best. The patient safety and the patient comes first. That is the motto. That is one of the commandments. And I think that is the most important commandment. Right now, I would say evolution of cardiac surgery. This was the operating rooms which we used to see. There is a good chunk. With miniaturization, our mobile phones started becoming smaller and smaller. Our pen drives started becoming smaller and smaller. And right now we are health conscious. We want to taste a burger, but we are calorie conscious. So we want a burger on the fork. So same thing. In cardiac surgery, everyone used to say that all the bones, your chest will be open. So the institute where I was trained, we had a Japanese collaboration, and a Japanese fellow used to come. So in Japan, there is some area where they say that if you put a knife on the chest, your soul goes away. So cardiac surgery was a contraindication in that area, and no one would put a knife on the chest. But having said that, the seeds for minimal invasive, see, in general surgery, we started with laparoscopic cholecystectomy. Then we went into lap and then hernia repairs and all that. But cardiac surgery, I would say, was the last one to accept minimal invasive because of the complexity and considering developments and more safety of the patients, the conventional method was the best option. So the seed for minimal invasives was shown rather by during the evaluation of pneumothorax in a patient of tuberculosis, and that was how minimal invasive thoracoscopy, I would say, started, and that was the seed for minimal invasive cardiothoracic and vascular surgery. So previously it was a dictum: big incision, big surgeon. The smaller the incision, the smaller the surgeon. So this was the class. So this was the classical incision where we have a midline incision and this big incision. Then we evolved to this right anterior thoracotomy. So the point was, I live in Indian subcontinent, and how we started, no doubt it started everywhere. But what was the major reason for? There were good number of rheumatic heart disease patients, and there were females. And if there is a scar on a female, then marriage, and most of them were at the marriageable age. So we started this inframammary incision where it can be hidden, and a groin incision, and what we call it as a bikini incision, where if you are wearing a bikini, there is no scar which is visible outside. Of late, we are now advancing more, that even with it's in the axilla, a 5 centimeter incision in the axilla, and treating a double valve rheumatic heart disease patients and multiple patients through the axillary approach. Your scar is in the axilla, and no one can make out that you have undergone a heart surgery except the patient knows, or maybe if it's a metallic valve, then there would be a click sound. Last but not the least is the robotic, where we do robotic cardiac surgery through ports. Just like laparoscopic abdominal surgery, we put ports in the thorax, in the chest, and we do surgeries like mitral valve repairs, mitral valve replacements. Okay. This is the perioral incision. This is the last. I would say we are becoming smaller and smaller. This is just hardly a 2 centimeter incision just around the perola, which this patient, this is, I just discharged him 5 days ago. He had the atrial septal defect, plus he had a mitral valve prolapse, classic mitral valve prolapse, which required a repair because it was severe mitral regurgitation. So with this incision, we just did a mitral valve repair. This was the incision through which, with long instruments, we put, we have knot tires and other thing, and we did the surgery. And the patient was discharged on day 3. Hardly any incision, less of pain, no trauma, walking, and no one can make out that he has already undergone surgery. Now, let us come. Now, this is about what are the indications. So, the indications can be aortic valve. See what I am talking, we are talking of cardiac diseases which require surgical intervention. I know there are certain diseases where we follow medical management, and once medical management is exhausted, we go for surgery. So the indications remains the same. But for minimal invasive, what we do is aortic valve replacement, mitral valve repair and replacement, coronary artery bypass grafting, complex ASDs, atrial septal defects, at times VSD, and pulmonary valve replacement, redo surgeries, and hybrid surgeries. I'll show you some few videos of what our approach is and how. The most important thing is it's a customized approach. So for aortic valve replacement, we follow two. One is a upper hemistenotomy, a 5 centimeter incision, depending on that. And there are indications for that. If there is a complexity, there are peripheral vascular disease with it. The patient has, we cannot go for peripheral cannulation. The patient is very obese, then these indications. Otherwise, my most preferable, if you ask me, 90% of my aortic valve replacements are done through the second intercostal space without cutting any bone. So this is the peripheral cannulation where we put one arterial and one venous cannula, one in the femoral artery and another in the femoral vein, which goes IV to the IVC. The cannulas are long. This is how the picture looks like, where we have put multiple to arrest the heart, to clamp the heart and vent the heart. And all these things are assisted by transesophageal echocardiography. And this is the final result we have uh, after we have done the surgery. So this is the incision you can see on the screen. This is the incision. This is the pacing wire, and this is the intercostal muscle, what we give as painkiller. It's sort of a thoracic epidural, which continuously gives initially, because we most of the patients we extubate on table, so that for time being we give epidural anesthesia for 24 hours, just like any other fraternity, maybe orthopedics or same similar, and the patient is pain free and can breathe normally. This is the incision for atrial septal defect with mitral valve surgery. I showed you this was what we used to do previously. Right now we have come to periolar incision. And it is not just, see, previously we used to tie, after valve replacement, we take valve sutures and we have to tie them. But I'm just showing you the latest technology. This is the core knot. Okay, I need not tie 5 knots with the knot tire. Just a click and the knot is tight. So it makes my life very easy in valve surgery. I'm just showing you here an overview. This is a case of atrial septal defect where I'm opening the pericardium. You can see that I am touching the right atrial appendage and taking a stitch on that. This is my surgical assistant. This is my anesthetist. These are all who are working ports, and here I am sitting on the console. And actually, it is not the robot which operates, it's robotic assisted cardiac surgery, what we call, with the help of my arms. And with this robot, I have now 4 arms instead of 2. So this is the cardiopulmonary bypass machine, which you can see my perfusionist is sitting, and this is a T going on. And this is how you continuously monitor your patients for the safety and all. Another thing I would say, tricuspid valve, the right-sided valve, has always been neglected in the past, but it causes a lot of problems. Patients who have already undergone double valve or mitral valve replacement and they come with tricuspid valve regurgitation and all that. At times they have undergone 2 times stenotomy and all that and becomes complex going for redo surgery. So I do it minimal invasive on a beating heart. So this is, I give a 3 centimeter, 4 centimeter incision in the chest, peripheral cannulation, and on a beating heart. This is the tricuspid valve. You can see I have taken the valve stitches and it is beating. And this is the peripheral cannula. So you can see the arterial and venous cannula inside. And with that, I'm able to do the surgery. And this is after the valve replacement. I have taken the stitches and the valve is replaced and the heart is still beating. And the patient's tricuspid regurgitation and the symptoms because of tricuspid regurgitation, ascites, hepatic congestion, swelling in the lower legs and all that, and patient becomes comfortable after that. This is the transaxillary approach through the axilla. We put so this is the incision through which we have done the double valve replacement. And this is the valve which I have put. So these are zoom this thing. So hardly the spaces that you just able to insert the valve inside. So this is the ultimate, and that is how we do. So this is the actual incision you have once you do a transaxillary double valve replacement. So it is hardly, the skin incision is 5 centimeter, and this is the actual hole because we need to put the heart valves through it. And this was an elderly patient above 66 and required bioprosthetic valves. So next we come is coronary artery bypass surgery. So we have multiple views of it. We do through a lower sternotomy, through the left anterior thoracic. Valvular regions are treated from the right side of the chest, and coronary arteries are treating from the left side of the chest. Because we use left internal memory artery, this is the OT layout you can see. These are the special instruments, these are the special retractors, and this is the small area which you can see through which we do the bypass. So this is where we have taken out the reverse saphenous vein graft, and we have a side biting clamp, and you can see, easily appreciate that that is the aorta. I'm making a nick in the aorta. And this is the aortic punch, which you will see. And then we anastomose this reverse saphenous vein. This is the aortic punch, where we create a small hole in the aorta. And on that we stitch stitch the reverse saphenous vein graft. And this is how we do once we have done this. So this is the instrument which is called the octopus, where I have stabilized a small segment of the heart. This is all done on beating heart. You need not arrest the heart. And on this beating heart, we do the distal anastomosis, where we put, here, this is the coronary arteriotomy, which I am doing with my blade. And this is after grafting. You can see this is the left internal memory artery going to the LAD. This is the LAD, and this is the vein graft, which is supplying the ramus intermedius. I'll show you another video. This is another video where we had done all the three. So this is, you can see, Lima to LAD. And you can see the two grafts, the proximals, which we have placed on the aorta. It's very difficult to insert your fingers, but yes, you can stitch. That is because of the help of the instruments. This is the right atrial appendage, which he is holding with the forceps. And this is the aorta, where you can see the proximal grafts. This is one graft you are seeing, and this, I'll show you. This is my surgical colleague. And here you can see the vein graft. Can you appreciate just below his finger? So this is how it looks like once we do the surgery. This is another, the new term, total arterial. It is like making a garland around the heart. So this is the left internal memory, this is the right, and grafting all the three vessels. So Lima to LAD, and to the OM, OM2, and posterior descending artery. So it is just no incision anywhere, just taking out two bilateral internal memory arteries and doing the grafting, total arterial bypass. These are cases who have previously undergone stents and stents get stuck. There is a stent abscess and all that. You have to remove it because these patients are suffering from infective endocarditis, not from the valves, but from the coronary arteries. So we have operated a lot of infective endocarditis, valvular patients also, but there is infective endocarditis true. There are myocardic aneurysms which develop in the coronary arteries. So you have to remove the stent, do the endarterectomy and all that. This I would just show you. There are heavily calcified arteries where stenting is not possible and everyone says surgery is also. So we take out the calcium chunk, which is called the endarterectomy. And this is, I am doing a LAD, left anterior descending artery endarterectomy, heavily calcified vessels throughout. And on a beating heart, with the help of special instruments, we take out, can you see till the apex? The whole segment is removed, and then we put a Lima 2 LED on that. So you can see the whole amount, the whole LED till the apex of the heart, the whole calcium and everything removed. This is the ultimate picture of that endarterectomy segment. This is a case who had a coarctation of aorta and had developed an abscess in the coarct. This young girl had splenic abscess. She had a torrential course, but it was the all cause was the stent abscess which developed in the coarct area. We removed that segment and did that. So with the advances, the newer, I would say, instruments, transesophageal echocardiography, endoscopes, robots, and the newer valves, we are much better off right now. These are the special instruments which make our life very easy and help us doing these kinds of surgeries. These are the latest valves. These are tissue valves. Previously, they never lasted more than 10. Now, their average lifespan is 15 to 18 to 20 years. What everyone? Yeah, we have results till 8 years right now, functioning well, but further needs. So, there are advantages of this minimal invasive in redo cases, in high risk patients, and the biggest advantage is limited blood loss and faster recovery. And most of the patients, they don't want stenotomy, but still, having said that, if you ask me, I just do 40% of the minimal invasive, 60% is still the traditional because it's a customized treatment. We do it, we have a checklist, we see the perioperative habitus, CT autograms and echoes, and on that, we have guidelines from international societies and all that. We follow those guidelines. This guy, I just wanted to show you a CT. This guy came for a minimal invasive cabbage. That is a protocol. I get a HRCT. Can you see the whole pleura was calcified? He had an old episode of tuberculosis, and you can see the difference between the right lung is hyperinflated and the left is small. So it was just encasing, no doubt his. So we did a total arterial CABG, but not minimal invasive open. We do a lot of things during the surgery. Pain management, it's a team approach. There are challenges. Doing stenotomy is not a failure. Things going south, just do a stenotomy. Patient safety and patient results are the most important thing. Does size matter or CPB timings? No. And this is the case which I would say we discharged this patient. She flew from and she underwent spinal surgery and developed massive pulmonary embolism when she was turned. We took her from the neuro OT to our OT. My OT is OT1 and the neuro OT is OT8. Put her on bypass, and that is the amount of clots we removed. This was ongoing CPR. Yes, this patient was discharged in 10 days and she is doing fine. These are the clots which we remove. I love my team. Thank you.
Dr. Udgeath, it would be very helpful
Okay.
doctor audience so that they realize when, like, what kind of conditions or what kind of triggers or symptoms they see in the patients, because most of them practice in resource poor environments, that that's clear to them when to make a referral to a specialist like you.
See, I would say the most important symptoms are I would say the valvular symptoms, what we get, like classic breathlessness, dyspnea on exertion, paroxysmal nocturnal dyspnea. I'm using these terms because this everyone knows. You have cough in the night, they cannot lie flat on the bed, they have chest pain, and then they need evaluation where we do the echocardiograms, the electrocardiograms, and we assess along with coronary angiography, and we make a diagnosis that these patients have valvular heart disease or coronary artery disease, or there is dilatation of the aorta. All these symptoms, the most important, see, I would say heart speaks. I know English and I know my Indian language. I will speak in that. uh, Other French will speak in French. So heart has its own language. It speaks in three, four ways, and that we have to understand. What are those three, four languages which the heart speak? It can cause tachycardia, means increase in heart rate, or it can slow the heart rate. It can increase or decrease the blood pressure. It can cause breathlessness. It can cause pain. These are the languages heart knows, and these are the symptoms which the patients will come off. So, basic, simple, heart speaks only these ways. So, if you are having any of these symptoms, get yourself evaluated by the physician. He'll auscultate. On auscultation, if he gets a murmur, there is a swelling, there is a jugular vein which is high CVP is shown. So think the rhythm is atrial fibrillation, and there is a uh, ejection systolic murmur or a diastolic murmur in the mitral area. Think that your case is a rheumatic heart disease with mitral stenosis and mitral regurgitation, and in atrial fibrillation with with high PA pressures, and then we can intervene.
There's a question
Yes.
from Dr. Francis
Yeah, yeah,
Piketty.
yeah.
What are the cost implications for these surgeries, sir? I know every surgery would have a different cost, but some approximate range.
I would say all the minimal invasive, I should tell in dollars, I would say.
Yes, sir.
Okay, so the cost implication for a minimal invasive, depending on the valve and all that, it ranges, and coronary and all that, ranges from 6,500 US dollars to 18,000, depending on the complexity and depending on the kind of consumables being used.
Okay. So we
So
have a
range,
question from Dr. Orwana Paul. He's from Nigeria.
yep.
His question is, how do you replace valves when doing robotic cardiac surgeries?
So we replace the valve similarly with robotic cardiac surgery. It's a robotic assisted, except for the small incision. We have four ports and those arms are working. So we have a cross clamp and all that. It is the same way as we do conventionally, except that in that the robotic arms are assisting. The long instruments which I showed you, which I am using by hands, I am using those instruments through the robotic arms. That is the difference. We have the same cautery, we have the same scissors, we have the same needle holders, and everything is the same, and we use the same sutures. So nothing changes except the approach changes. And instead of my two hands and my assistant helping me, here I have four arms because of the robot, and one arm I can change one arm to another arm simultaneously.
So we have a question from Dr. Gosa Abebe from Ethiopia.
Yeah.
Which cardiac abnormalities are not a candidate for air transport?
Pardon?
So which cardiac abnormalities are not a candidate for air transport? So many times, there might be patients who are complex, they need intervention, but they may not be fit to fly.
We
Which,
have flown multiple complex cases even. I would say acute dissection and the patient in gross failure requiring oxygen requirement more than 5 liters per minute, more than 5 liters, I would say that becomes rest. We have shifted patients of dissection also, acute coronary syndromes also. So we have shifted. But the point is, basic thing is, it has to be a teamwork between the guys who are shifting and the place where they are coming. So we shift a lot of patients on ECMO also, and I would say there is no absolute or relative contraindication, but depending on that, high inotropic support, patient is hemodynamically unstable, requiring a lot of inotropes. He has multiple, means the whole Christmas tree of inotropia, and rhythm is unstable. So those patients ought not be shifted. They have to be taken care then and there itself. I
There's
hope.
a follow-up question from Dr. Ornana Paul. So when doing cardiac wall replacements, how is heart able to keep beating while you are replacing the uh, uh, defective wall?
So this I showed for the tricuspid valve. The heart is beating because we have already bypassed. Okay. So we do the peripheral cannulation. We put one cannula in the aorta, which gives blood to the heart. And this was right-sided. So there is no chances of air embolism. I am not opening the left side. The blood is flowing and the venous return, because I have snugged the SVC and IVC with the cannulas. So blood from the upper body and the lower body with the help of cardiopulmonary bypass goes to the machine, and that through that roller pump the aorta is pumping and still heart is beating, and we cool the body because we have a thermistor along with it. So we cool the body to 30 degrees, and the heart is beating at a slow rate, and we are able to stitch it, and still beating we do the surgery. That's good for heart. Beating heart is always good for, means that is what heart is made of. It ought to beat. Yes, at times we have to arrest it to do aortic valve, mitral valves, and heart transplants and also and acute dissections and all that. But yes, there are certain situations where arresting those hearts can be detrimental and they might not come off pump. So those are the conditions where we do on beating heart, and that's why their results are very good. I hope I answered your question.
Okay. So any other question from any member of the audience? If you have any patient cases, complex cases, which you think might help you discuss with Dr. Dhir, you can do it now. Okay, so there's a question from Dr. Dinawal. Dr. Dinawal is from Ethiopia. What are cardiac procedures done by cardiac surgeons but not by cardiac thoracic surgeons? He has some confusion here.
So see, where I've been trained, we have been trained for both cardiac, thoracic, and vascular surgery. So cardiac surgeons do only coronary and aorta. Vascular surgeons does thoracic aorta and abdominal aorta and the peripheral vascular disease. Per se, these are gray zones. Your expertise, I do mode of coronary, valvular, and aortic work and heart transplant. So that is my arena. One of my team members, I assist him. He is my junior colleague, but I assist him to do peripheral vascular. He is fond of perivascular. And both of us have been trained as a cardiothoracic and vascular surgeon. So these demarcations, right? See, I would say these are not super. These are micro specializations which we are. We are not super specialists. We are micro specialists. So it's typically what you like the most. I love coronary. I love the valves. I love MICS. That's my passion. I love aorta. So I do that. Uh, my colleague loves peripheral vascular. He loves popliteal. He loves femoral and all that. So that is the way trained in. But yes, your passion and your, I would say, every physician, someone loves treating rheumatology cases, someone loves dermatology, someone loves ophthalmology. So this is like that. And in cardiothoracic vascular, we have good organs. Organs remains the same. It's just the heart, lungs, and the lymph nodes and the aorta. That's all.
So we have a comment from Dr. Sunday. He's a general surgeon in Nigeria. I mean, thanking you for the presentation.
Thank you.
Again, from Dr. Dinal, who just asked the questions, he thanks you. And if we have no more questions, all of the African doctors present here, they have their work group with us. If you have any follow-up question around this topic, you can ask us in the group. The team will direct it to Dr. Dhir and we'll get a response to you. Dr. Dhir, one comfort that I wanted you to give the doctor attendants here, that many times they see complex cases and because of the most of them are practicing in developing countries like India. So many times patients, very clear patient need intervention outside, but because of monetary issues, they may not be able to make the trip or they may not be able to afford the treatment. In those situations, sometimes it helps them if a super specialist or a specialized surgeon like micro specialist like you can point them in the right direction. So we always assure
See,
them.
point is, first of all, we are all doctors and we are for humanity. That is the first motto I said. So if you ask me what I am doing here, I don't want to just project myself and all that. There are patients who say, I feel the treatment should not be denied because of monetary reasons. That is my strong saying. And I would say from Fortis organization, I have been with Fortis organization for last 9 years. Never ever had I any problem. Means whenever I've asked for help, for monetary help for a patient who needs that, it has never been denied. So I can assure you from myself and from my on behalf of my organization as well. Okay. I never had any problem. It's 9 years now. Never ever, if there is a patient who requires a treatment and his treatment is denied just on the basis of monetary things, it has never happened. And touch wood, I pray to God, it should never happen also in the future. That is all I can assure. Second thing, if you have any query, you can take down they can provide my personal mobile number or a WhatsApp number where you can call me and share and discuss with me. I am available, yes, after my OT hours. That timings may vary, but I am always available where you can discuss any complex things and what you feel like, any new thing which you can do or you intend to do a new thing. I am always available there. That is all I can say. I feel
Uh,
treatment delayed or is treatment denied. Just like everyone says, justice delayed is justice denied. So I feel treatment delayed is also treatment denied. The treatment should not be delayed or denied on any basis. It's the
Thank you,
clinical thing. Yeah.
thank you, Dr. Udgit. We also, when we interact with African doctors, we assure them that, even if you feel there are constraints, you can write a doctor's note, a brief doctor's note. Indian doctors, most of them are very happy to help beyond immediate duty reasons because quality healthcare should be accessible to all in today's technologically connected world. Thank you, sir. And we have a compliment from Dr. Dinal, uh, 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 and again from Dr. Aruna Paul, both uh, complimenting you on the presentation. If you have no further questions, we can conclude the meeting. And as Dr. Udgit said, if you have any question or any doubt about any patient that you want to discuss, please share with us. We will ensure that it's shared with Dr. Dhir, and based on his response, whether his note help or his talking to you help, we will arrange that. Thank you, Dr. Dhir. At Jivo, we are trying to foster collaboration
Thank you.
between doctors from different countries so that patients.
Thank you.
My question is, sorry, my question is not raised.
Thank
I have,
you. Thank you.
I have presented one question.
Yes, please
Uh,
ask Dr. Gosar. Please ask the question.
yeah, okay. Is there a patients who are not candidates, cardiac patients who are not candidate for air transport, specific particular to if you consider referral?
Okay. So basically, sir, Dr. Udgeath, Dr. Gosa had asked that question, which cardiac abnormalities present are not a candidate for air transport. I think he wants a clarification that if he makes a referral, Dr. Gosa, if I have understood you correctly, you want to check that if you make a referral, which are the cases which would not be fit for air transport, and hence,
I think I answered that question. I said that all patients, except who are on heavy inotropes, all of them can be transferred with appropriate medications.
and Dr. Gosa, if you have any such relevant patient based on the current medical reports, they can be shared with Dr. Udgeet and they will guide you. Many a times, if a patient is too far advanced, generally they will not meaningfully benefit the Indian specialist ratio. So in that case, when you see such a patient, it is better to share with us so that we share with
See,
Dr.
what we do is we do a video call, we see the parameters, we see the arterial blood gas, we see the clinical condition of the patient, and then take a consensus decision what to be shifted, what not to be shifted. There are certain patients in medicine, there is one law, there is no law. There are everything is clinical and everything is dynamic. Nothing is static. Everything moves. And a stable patient may become unstable in next 2 hours, or an unstable patient may become stable in 2 hours. So we have to optimize that and then plan airlift. So it's not means yes, there are certain patients we were not able to airlift because of the hemodynamic compromise. But most of the patients, that is what I told, even on ECMO, we can do a ECMO and we can shift those patients.
Thank you, Dr. Udgeet. Thanks for your time. And thanks to all who attended on a Sunday. Most of you get Sunday as the only free time, and we engage you in these educational activities. Thanks for being there. And again, a comment from Dr. Gosa who asked this question. Thanks for the nice presentation.
Thank you.
Thank you, Dr. Udgeet. And if you have any questions, Dr. Udgeet, any cases to refer or any complex cases that you want to manage with his inputs, please feel free to share. Jivo team will arrange that. Thank you. Thank you all.
Thank you.
Thank you.